All righty. Good afternoon, everyone. My name is Janiyah Donson. I'm the communication specialist here at NISAR, and I want to thank you for joining our session today. Update on Rural Health Clinic Compliance. Before we begin, I want to share a few of updates that we have. Our call for abstracts for the 2026 Public Health Partnership Conference is open until November 13th. We're looking for presentations on topics like workforce development, technology and AI in public health, and policy implementation. The conference will be in Lake Placid from April 22nd to the 24th, and we'd love to see you there. Also, don't forget that we have our National Rural Health Day on Thursday, November the 10th. We'll start at 10 a.m. with our Rural Health Day award ceremony, where we'll be celebrating people making a difference in rural health. And then at 1 p.m., we'll have a speaker from the National Rural Health Association sharing federal updates from both Congress and the Trump administration in order to keep rural health leaders knowledgeable about the national policies that might impact the provision of healthcare. Chess credits will also be offered for that session, and I will drop the links to the chat to both of these registrations. And we will be offering chess credits for this session that we are having today. We are sponsored by the New York State Association for Rural Health and the New York England Rural Health Association, a designated provider for continuing education contact hours and health education by the National Commission for Health Education Credentialing. This program is designated for a certified health education specialist and or a mastered certified health education specialist to receive up to one total Category 1 continuing education contact hour. Maximum advanced level CECH available are 0 and continuing copy credits available are 0. And our provider ID is 100693. The mission of the National Commission for Health Education Credentialing is to enhance the professional practice of health education by promoting and sustaining a credentialed body of health education specialists. To meet this mission, NCHEC Certified Health Education Specialist promotes the professional development and strengthens professional preparedness and practice. And for today's topic is the Rural Health Clinic Compliance. We'll be learning about the basic of compliance, common issues clinics face, and how to avoid them. We're very excited to have Kate Hill with us today. Kate is the Vice President of Clinical Services at the Compliance Team. She is a Vietnam Army nurse veteran and a Bronze Star recipient. Kate has spent her career helping rural health clinics improve care and meet compliance standards. She also serves on the board of National Rural Health Association and works closely with clinics across the country. After Kate's presentation, we'll have time for questions, so please drop them in the chat at any time. Kate, thank you for being with us today, and the floor is yours.
Okay, well, let's get those slides up there and get started. Hello, New York. I'm right down here in Pennsylvania, just south of you. And actually, we'll spend Thanksgiving in the Catskills with my family. I'm very excited about that. So, a little New York connection. All right, so let's get started. I'm going to turn my camera off so you're not looking at me, you're looking at the slides, which is what's important. And we'll get going here. We're going to talk about the most common deficiencies we've seen this year. We're going to apply practical strategies to integrate compliance into your daily clinic operations and processes that reduce survey stress. That is so important. We will start with the number one deficiency across the country, not just in AOs, but in states. We verified this. It is a problem. So those of you who are clinical on the call, you're going to be like me and roll your eyes at this one. But here's the issue. Single dose vials having a 28-day date on them, not acceptable. There's no preservative in that vial. You don't know if it's good tomorrow, let alone 28 days. So you might have ineffective or unsafe medications. So per CMS, one vial with a 28-day date on them is a failed survey. That was an argument I lost, that one is not human error, one is a failed survey. So let's be sure that we're going back and teaching that single dose vials, once the rubber stopper is penetrated, we are putting it in the recycle bin. If it's a multi-dose vial, then a 28-day day goes on there, and you want to teach your staff to do that as well. So do not assume everybody knows the difference. And again, I know that most of you are rolling your eyes, probably all of you are rolling your eyes, but we see it. We saw it this very week. So it does happen around the country. There is a guide that helps. Number one, if you can't figure out what 28 days is from today, and it's quick math, but still, this little thing you can print, go to gohcl.com. It's public document free. Print it out. You can get the 26 one soon. And then you hang it on the door, and that's going to be a reminder as well for the 28-day vials that if you opened on April 25th, the expire date is May 23rd, and you never want to give the drug past that day. So, drug administration, as I said, is a big problem. So, be certain that you're using the proper use of single dose versus multi dose vials. It's in your policy, you're teaching it at onboarding, and I would even review it annually. Is there a policy on keeping all medications locked, secured in your clinic? What does your policy say about a power outage in the clinic? What happens when the lights go out Friday night and they come on Sunday night? But are those drugs safe Monday morning? You need to know that. You need to have a policy on that. Do you have a log for your samples? We must log where we give every sample in the case of a recall. Does your policy spell out how often you check for outdated meds and supplies? Does your medication refrigerator have water bottles in the door? That's the recommendation of the CDC, that we take up that dead airspace so we don't have uneven temperatures within the body of the fridge. Are you using a dorm style refrigerator? Not acceptable. And I have a picture of that further on. And do you have a log for every controlled substance that's within your clinic? Even if it's one person's vial of testosterone, which is what we see most commonly, you need a log for that so that every dose is accounted for that is required. Samples, as I said, need a log and to be organized. So this clinic was in West Virginia. I surveyed this many years ago. It's an old picture where they had 12 different colored dots. So we are now, let's say we're pink in early November. Let's say October was orange. You open that door, those orange stickers are out of there. It makes a lot of sense and it saves a lot of time. As you look at every little box and the expiration date, that just makes good sense. It is not a requirement, certainly, but it saves a lot of time for your whoever's doing your checks. And here's the refrigerator with the water bottles in the door. If you buy an expensive medication refrigerator, which we often see in hospitals, there's no shelves in the door for that very reason. So we don't buy those mostly in clinics. We see them once in a while, not often. They're very expensive, not necessary, but you want to take up that dead airspace. Now, whoops, sorry. If you're accredited by us, you do not need to label it food. We know why it's there. But there have been a few state surveyors that have said that must be food. And I apologize why these are jumping around. I don't know. And it is not food. We know that's not for drinking. So this is an example of a dorm style refrigerator. You see that the ice here, there's buildup. So a dorm style refrigerator is defined as one that has no separate door inside, or it has a little door inside the big door. And so it's not even temperatures. And so you never want to use that for any medications at all. You could use it for lab samples, I suppose, but not for medications. So let's go back to where we start this survey and get you survey ready. We're going to walk in the door. We're going to make sure the name matches what you told CMS you were called. And believe me, this does change. You can go to QCore, the government website, and see what you're called. Just plunk in your CCN. Do you have your hours posted? Have they changed significantly? I'm not talking about an hour here, but all of a sudden we have no provider on Friday, so we're closed on Friday. You really want to reach out to your accreditor or to the state to say that that's changed temporarily, whatever. Just an email, because should they show up and you have no indication of anything on that door and you're not there, you really could have a problem. And it has happened, even in your state. And it's a long story. When we enter, we're looking at that waiting room. Are there trip hazards? How do you disinfect all those toys and how often do you do that? Very, very important, especially with sick children. And they're pretty messy. Can I hear this person here calling out labs? Now, if you can tell, there is a glass shield on this one, but that is not always the case. And so we want to make sure that she's not calling out labs and I can hear that, which of course would be a HIPAA violation. All the equipment in the clinic is on a list, and you want to make sure today, start making your little checklist of what you're going to do today, tomorrow, whatever, that everything is on the list. You haven't bought a new piece of equipment that didn't make the list, and it's been checked for electrical safety or calibrated within the year, never more than a year. So it could be stickers, that's acceptable, or it can be a list presented to you by the person, the biomedical engineer doing that. This is new to us. This just happened this week. The AED normally does not, the company checks them, but you have a battery checker and you check the pads for expiration. Well, on Monday of this week, we had a survey where the surveyor was really spot on to notice, because don't know that I would have noticed it. It was a lesson for all of us. They had the wrong pads in there and they would not have worked with that AED. Wow. We're glad they didn't need that AED at that time, but they quickly ordered what they needed. For whatever reason, the wrong size pads came or the wrong connection, whatever it was, and would not have helped the patient. So check for that. That's a new one for us, as I said, but live and learn every day, something new. So again, all the equipment that needs calibration or a safety check is on a list. And the only way to know the difference is checking the manufacturer's instructions for use, because you and I don't know just by looking at something, but you need to find out. Many scales can be self-calibrated, and you should do that annually, particularly baby scales, but then keep some sort of log that you did it on January 2nd or whatever your date is to do that. Of course, infection prevention is a large topic. We never want to spread infection, and we are noticing. Now, I've been a nurse for, well, you heard my Army days. I'm over 50 years a nurse. We were talking then, and probably well before then, that hand washing is the most single effective way to prevent the spread of infection. And yet we cite it frequently. The nurse, the NP, the physician never washed their hands or even used an alcohol-based gel between patients. The MA is doing medications and didn't wash their hands or even put on gloves. Please, please, please go back and uh, reiterate that this is the single most way to prevent spread of infection. So hand hygiene is critical. Safe injection practices, single-use devices, once and done, no matter what they are. Safe use of the point of care, any point of care devices. How do you clean the surfaces in the clinic? What do you clean between patients? What do you clean daily? What do you clean weekly? That sort of a thing. You should have some sort of um, policy on that, and it should be posted near or where the staff sees it. Does not have to be for patients to see, but in the break room perhaps. How do you dispose of waste, medical waste especially? What do you do for pest control? Measures to maintain a clean and orderly environment. And always, always, always signage to separate a clean area from a dirty area. Many of you, because of the size of our clinics, are doing medications in the same room we're doing labs, and we need clean over here for the meds and dirty over here for the labs, and never should the two meet, for sure. If you have one of these little guys, this is a tabletop sterilizer, works well. If you have one of these, I want you to do this. Pull the manufacturer's instructions for use on an M7 Speedclave or whatever yours is. Compare it to your policy. Are you handing sterilized instruments to the provider when they need one? And that's really, really important. And that's what we're going to do on survey. We're going to compare the two and make sure it's set up properly. For a long time, it had a very high fail rate on this one, but now that we're speaking about it constantly, we're finding that people are getting that better, and you really do need to do that. Now, if you are transporting your instruments to the hospital for sterilization, we're going to look about your process. What are you cleaning them with? Is there a wet time? Is there a soak time on that? Did the person wear gloves? How are you transporting those instruments to the hospital? Is it a leak-proof container, considering there may be contaminants in there? And then after that, what do you accept back? You need to know the hospital's system. Should these lines be black? Yes, mostly. If they're not, should there be an expiration date on there? Were these forceps sterilized in a locked position? All those things. If you accept an improperly sterilized piece of equipment and it's in your drawer, you get the deficiency, not the hospital. We're surveying the clinic, not the hospital. So let's make sure somebody knows what their system is, so we know what to accept. Fire safety typically goes by the state requirements. I personally wish that everybody would have a fire drill every year. It's not required, but it is a great idea, best practice. So let's first, for what we're looking for is that fire extinguishers are mounted and checked once a year. You have signage that leads me to an exit when I come out of an exam room. Do you have to put floor plans up? Nope. If I come out of an exam room and I can see that lighted exit sign, I'm good. If I can't see it, tell me which way to turn toward exit. I don't need a complicated floor plan that sometimes can take, I know in hotels, because I always look at them. It could take 15, 20 seconds to figure out where I am and where that door is, but this is the best way to do it. The back door needs to be locked for your safety, and it needs to be a push bar or a deadbolt to get out, not a key. So we don't want to have to look for a key to get out the back door in the case of a fire or any kind of emergency. Okay? The lab. So we're all celebrating that we only have to have 4 required tests. Took a while to get that changed, but it's changed. So we don't have to do fecal alcoholic blood or hemoglobin or hematocrit any longer, because most people were not ordering just that. Most of you order a complete blood count. And so we have to do chemical examination of urine by stick or tablet, blood glucose, pregnancy tests, and culturing, which is drawing blood or culturing a wound, sending off to a lab. Those are the 4 required tests. Make sure your CLIA is current, and please note that in March, all CLIAs will be renewed electronically, no paper. So if yours is in the system, you should start looking at that now. There's a QSOG memo on that right now circulating. These vacutainer tubes have expiration dates, and people tend to forget that when they're looking through the clinic for expired items when you check once a month. So make sure that you have that. And also in the labs, we see unsecured sharps. Patients are left alone in the lab sometimes, and so we want to make sure that we are checking them or locking them, excuse me. Now, this is the CLIA lab, and I forgot that I put this in. This is important. Starting in March, all CLIA programs will be fully paperless process. They are one of the slowest processes in the country, in the government, I will say, very slow. So you don't want to wait till last minute. Now, if your clinic HIP CLIA expires and you've applied for the new one, show us that paperwork and we'll work with you on that. Just because the paper didn't come doesn't mean you didn't ask for it. So make sure, but no paper as of March. Oh, after March 1st, no paper. Okay. Now, your medical director is a reportable event. It is the person ultimately responsible for the care of everybody in your clinic. So you make sure that if you change your medical director, you complete a CMS 29, and that's the paper on the right, and you send it to your accreditor or to the state of Maine, so that you are on record with the proper medical director. So what are the duties of the medical director? 3 duties: chart review, collaboration with APPs, and signing off on policies. How often? Every 2 years. And I apologize, I didn't change that word Texas to New York there. I missed that one. But NPs have reduced practice authority in some states. Uh, you need to know what Maine does. If Maine gives no number, then you choose a number, you put it in your policy, and you say, our medical director will review 10 charts per quarter, and then you're able to present those 10 charts in a list to the surveyor to show they were reviewed. The best practice is to have the nurse practitioner countersign that log that the medical director or physician signed off on, because that proves her collaboration. It's a tough one to prove. We know they talk. CMS wants us to prove it. It's a challenge sometimes, but when we ask, they say, yeah, I talk to them when I have an issue. Sure. So make sure that you have the number of charts to be reviewed in your policy and that you're living by that number. Okay. Physician oversight. So what does your policy say about physician chart review and the evidence and what you're showing that surveyor? How do you document that collaboration? There's a bit of a duplicate, I apologize. Did the physician sign off on clinic policies? Remember, every 2 years. Now, the medical director is responsible for everything that happens in that clinic. And we get this question a lot. Can any MD sign off on policies? Yes, in fact, the law says MD or DO. It doesn't say medical director, but he is responsible, he or she. So let's get him to sign off on those policies. And again, if the medical directors change, notify the state and your accreditor. This is relatively new in January of 25, 491-8 updated to include clinical social worker, clinical psychologist, marriage and family therapist, and mental health counselor. They put those new types, and it's a wonderful thing, at 491-8, which is the spot that allows those folks to be independently practicing in the clinic. In other words, you have no APP there, no MD there, just a family therapist. How's that work if you have a medical emergency? I'm suggesting that you should update your emergency services policy to say, what's our process when a mental health worker is seeing patients? They have to have CPR still, but they cannot administer drugs. So we want to make sure that you're covered for that medical emergency. For the others, for your medical emergency, of course, you have CPR, medication, drugs, call 911. For the medical mental health, perhaps it's CPR, call 911, and that, of course, makes sense. Your APPs must be available to provide patient care services at least 50% of the time that the RHC operates, and that's your NPs, PAs, and or a midwife, which we don't see many of these days. So you must provide primary care. We're good with 2 patients or 100 patients. So the law changed in January to say you do not have to be 51% primary care. You have to be 51% of whatever, as long as you are providing some primary care. Be careful what specialist you add for the simple reason that, and this isn't going to come from my end, you're going to check with billing experts to see if this orthopedic surgeon is going to be part of our clinic now, maybe even 2 days a week, whatever he's going to do during his hours, are we covered by our AIR? Because if you're not, you're going to eat those joint injection medications and you need to check on that. Okay. So it really depends on the specialist and what he's going to do in the clinic hours. And that is coming from your consultant or your billing advisor. We still are under the restriction that we cannot be more than 49% mental health. But remember this, and I am fighting for this at NRHA. I'm on the board and we are working hard to get that to go away. We're not there yet. Right now, we can't do a thing, but we'll hopefully get there. Um, there are only 7 codes that an RHC can bill under mental health, and substance abuse is not one of them. That is medical, and that is a great help when you're in an area where there is a lot of drug abuse. You go over 49% so quickly once you start doing Suboxone and some other things. So remember that, because that could come in handy sometime. We need mental health. There's no question we need mental health, but we can still only do 49% of it. And we hope that will change. So as I mentioned before, we must have a 911 policy called emergency services. You must have a portable emergency drug box. Now, the contents of that box are decided upon by your medical director and your APPs. So we know where we're located and we know we need 15 things. Perfect. We're 30 minutes from an emergency service or a hospital. We need a robust box. If your clinic is in the hospital building or across the street, you may have 4 things in there. That is acceptable. You still need an emergency box either way because it's called out in the law, but the contents of it are your choice on and determined on by your needs and your location. So make sure that in your policy, and this was a gimme from CMS a couple years ago when they didn't, that whole list of drugs that we had to have in there, which included toxins, toxoids, and antibiotics, which are not emergency drugs for the most part, were in there. We don't have to do that any longer. The reason the list of drugs that's in the box must be in the policy is the medical director signs off and says, this is good. These are the drugs that we do need. And then you should print that list and put it near the box so the surveyor can compare the list to the policy, and it should be exactly the same. If we say we have 2 of something, there should be 2 in there. Check it for outdates regularly, make sure it's portable, and you should have 1 tank of oxygen with oxygen in it for a medical emergency in the clinic, and then you're good to go. Now, this slide came from a long time ago. I actually surveyed this clinic myself in Kansas. 22-page report. Everything on that counter is expired. It was quite a report. So just bear in mind when you're prepping, when you're checking the first of the month, you probably just did that for November. Everything that has a date is to be checked. When you're in the survey window, do it once a week. Make sure you know there's nothing expired in your clinic. Now, on these gloves here, yes, they're expired. And I'm not going to make a judgment call here, but if they expired yesterday, could you use them today? Well, you need to make that judgment. But for survey purposes, you're going to mark them with a big Sharpie that says not sterile, because that's what the manufacturer is telling you. We're not doing surgery in a rural health clinic for the most part, but they could have a good use for something else. They're certainly clean. So make sure you don't throw them away. And this sharps container in a patient area is not acceptable because I can help myself to some dirty needles. This red bag container has a biohazard sticker for the simple reason that it's not red and it requires a biohazard sticker, even though it has a red bag in it. This bottle of sterile saline that is now open is not sterile and that should be discarded. There's really no good use for that beyond that. Now, the Curad and I'm sorry to have the brand name there, but we're seeing a lot of deficiency this. This is a sterile packing gauze, and once that top bottle is open, it is no longer sterile, and you really wouldn't want to be packing anybody's wound with it once it's open. So please discard that after or find smaller packaging, whatever you need to do. Do not leave it on the shelf. You will get a deficiency for that because it's represented as being sterile. So we're moving closely. I pulled up the 2026 New York OSHA poster today so that you would see that. It's time to start thinking about ordering that, although with Amazon, you probably could have it tomorrow. But for the postings in the clinic, you need HIPAA, your privacy posting. You need patient rights and responsibilities. And for the staff, you need the 26, soon to be 26, OSHA and federal New York State hiring law in the staff area, mostly in the kitchen. Mobile units are growing. Is it a good fit for you? I would suggest that this is a financial decision that you make with your advisors. It does take a while to get it going. The first couple times out, you may have 4 patients and you've tied an NP up for 5 hours or whatever, or a day. I had a call this morning with someone that's working extremely well in schools, in rural schools. We get permission slips at the beginning of the year. The kids are allowed to go in there. They get permission to immunize, treat kids, get them back to class. Mom doesn't have to leave work, et cetera, et cetera, et cetera. But they do work. There are some very specific rules to that. You can add a van of some sort to your current RHC by going into Pecos and filling in the information. You have to have the VIN number. You have to have the locations. All the locations that that mobile's going to stop must be in a HIPSA. So we're going to make sure that we have that. It's a great way to enhance your revenues. But you have to, again, be in HIPSA. You must post those hours somewhere, mostly on the vehicle, at the clinic, in social media. If you have a vehicle that a mobility challenge person can't get in, you must catch that at scheduling to say you need to be seen in our brick and mortar building kind of thing. Okay. You can change the hours, you can change the locations by doing an information update in Pecos on your clinic. But again, that is a financial decision that you need to make with your advisors. When surveyors come, they will look at 20 charts. And most of the time, the issues are in very few places. The first one would be consents. They never made it into the record, number one. They're in a pile somewhere. And I will say, if you find the consent by 5 o'clock, you're good. Just show us and then get it scanned in, right? The other thing with the consent that becomes an issue, I don't know what's doing that, is the children's consent. So if I bring a child, it's going to be Kate Hill Grandmom, and you know me, and we're good to go. You need to be protected to who's bringing that child. We're not talking about emergency services here. We're talking about routine visits, okay? On the labs, big issue when we have an abnormal lab, especially, and there's no note in the chart. We see the abnormal lab, and the next note should be what we did about it. Number one, patient notified. Did we bring them in for a retest? Did we put them on a medication? Did we say we're going to watch this? Whatever it is, there's a note there to prevent gaps in care. That's all that's about, and that becomes a big issue. So make sure you're doing 10 charts a quarter for completeness. And you can use the log on your checklist that says, all the elements at 491.10 or make your own. Just Google 42 CFR 491.10 and you get it. And there's your log. Okay. How have your charts been signed off? Are we closing those records out in a timely fashion? What is your sign off time? It's become a little bit of an issue lately, I think, because people are so busy. Most people say I get them done that day, but that's not always possible. We're very busy and I have to get out and pick up my children or whatever, and it didn't get done. But how long do I have to sign off? 24, 48, 72 hours. 7 days is about the longest that I've heard, and that's probably about the longest it should be. Something happens to that provider, those charts are incomplete. We don't know where we are with that patient's care. So let's make sure that we are doing that. So these are the policies that are required and reviewed every 2 years. Everybody go write this one down. Make sure that your last policy review sheet with the 3 required signatures is not more than 2 years old. And if it is, get working on that. So who are the three people? An NP or PA, an MD or DO, and an outside person. So for provider-based clinics, this is a relatively simple process to find that outside person. You don't even have to pay them. They're typically on the hospital payroll, not on the clinics. You independent clinics have to find someone that can sign off on your policies. That can be a consultant or a local pharmacist or nurse, somebody that's relatively capable to look at a policy and say that doesn't quite sit right. But these are the policies that are required. There are many other policies. Some of you get policy heavy, but you need infection prevention, preventive maintenance, and again, I apologize. Drug policy, your cleaning and housekeeping, how you staff your clinic, your patient care policies. In patient care policies, where is it that an NP can go look something up? If I want to research measles today, where do I go look? That resource must be in the policy because the medical director is going to sign off that it's a good source. Most of the time, and I mean most, 95% of the time, we hear up to date or Hippocrates, which are built into your EMRs, and they're quite acceptable. If we ask your NP where she'd go research measles, she would say that. So just prep your NPs for that. Patient care policies, HIPAA, of course. Now, provider-based clinics, you're going to follow the HIPAA policy. You're going to follow corporate compliance policy of your hospital. That would be surprising if you didn't. You're going to follow hiring, training, and orienting staff by what your policy says. Probably your patient health records are going to policy is going to be your hospital. Your emergency services is unique to the clinic as well as your emergency preparedness. And I skipped right over description of services provided. This is in the regulation that you have a couple of sentences that sounds like a mission statement. This is what we do. We take care of patients' health from birth to death, and we refer. And that's where you put a couple things that you don't do, such as mammogram, colonoscopy, surgery, those things, and you're covered with that. It's in the regulation, so you do have to have that written in your policy. Now, next assignment, program evaluation, required every 2 years. Everybody today, please get a date on the calendar when yours is due, and then back that up by about 4 months with a date on several calendars on get ready to do program evaluation for this simple reason. We come back in 3 years, and that was due last year. And if you didn't do it, it's an automatic failed survey. So please, please find out what the date of your last program evaluation was and get some notes around that people will start asking, why is this on my calendar? There is turnover. If it's only on yours and you're moved on, nobody even knows it has to be done. And that does happen. Now, you are reviewing 10 charts a quarter for completeness. You are your medical director is reviewing charts for medical care. Dump all those files into a folder so that when you get to program eval, you have a good hefty number of 80 or better charts, and that's what we need. Make sure every once in a while you evaluate a closed record because it's required for program eval. One is enough, but you do as many as you wish. But make sure you do one and mark it. So what is a closed record? Well, it's obviously a deceased patient. It's a patient who asked for their records to be transferred. And it's a patient who's not been in the office for 3 years, which is Medicare's definition. So any one of those, mark it closed, evaluate that chart for completeness or whatever. Make sure you include it for your program eval. And then after you put this report together with all the data that's required, and that's not on this slide, you're going to analyze it. So what did we find? What are we doing well? What do we need to fix? Have we lost a payer? How did that happen? Maybe some company closed and that was the big payer there, all that. Then you share that information with your staff. So we're looking for the information, we're looking for the analysis of the information, and we're looking for your staff signatures that you shared that information with the team so that we can move forward better than we did the last 2 years. Emergency preparedness is, of course, a big issue. Make sure that you have your risk assessment. And your risk assessment is evaluated every 2 years. How are you going to make a note that you reviewed that risk assessment? Nothing's changed. It's the same old ones we had last time. Then at least, at the very least, initial it and put a new date. So we know it was analyzed. So we know nothing changed. The weather may or may not have changed to evaluate Maine. However, maybe there was a factory built near your clinic, or a highway went in, or a school popped up. Different things happen. Just make sure your risk assessment is the same. And your plan for each risk is well written and still appropriate. Now, on your communication plan, I really am sad when I see this as a deficiency. It is a bunch of phone numbers. My goodness, we should just go down the list and make sure we've got all the staff, any other entities providing service, another RHC or FQHC. You don't need to ask their permission, you put it there. Let me jump to federal, state, tribal, regional, and local emergency staff. All those phone numbers. Don't miss tribal, but if you don't have one within 50 miles, you put a note in your communication plan, no tribal clinic within 50 miles. You must also address volunteers. Our clinic has decided to not utilize volunteers, which is about 100% of you. We have yet to see them in volunteers. You know, and I know, in a real emergency, the volunteer is going to be any able-bodied person that can help right now. So we don't uh, train them and HIPAA train them on EP train them like hospitals do in a clinic. At least we haven't seen that. You could, if you have volunteers, you are going to name them and train and proof that you've trained them. Okay. What's your alternative means of communication should the landlines go down? Again, most of the people, it's cell phones. If it's not cell phones, if you're in a hospital system and it turns out to be um, walkie-talkies, two-way radios, you have to show the equipment and explain how it's used. And then have you trained your staff? So you've gotten all this written. Now we sit our staff down and we train our staff and we get their signatures. That's the bulk of it. Now, every year, once a year, we test our emergency plan. We have an actual event. You very well might have a blizzard this winter and the power goes out and you don't miss it, write it up. You could, if not, you're going to do a tabletop exercise or an active drill where people are moving. Maybe a tornado drill. I don't know if you get tornadoes up there, but why did I say Maine? I'm talking to New York. I don't know where that came from. But at any rate, in New York, you do get blizzards for sure. So when we come in 3 years, there's going to be one for every year. And make sure you have that written and documented. And again, the same thing holds true for that program evaluation. You must analyze it. So what were the strengths that we found when we did this exercise? Now, that one on the left is a community-based exercise. We are not seeing that. CMS understands why we're not seeing that and are good with clinic-based exercises. Simple reasons. It costs money. You have to do it on a Saturday. It's a big event. Some people still do it, but not very often. More hospitals do a drill like that than a clinic. You certainly can do it, but it has to be analyzed, and that's what we're talking about here. So what did we identify that we should improve on by that exercise? What action plans have we taken? And again, review the report with the staff and the assignments that need to be given and attendance at that after action report meeting is written. And it really is important that you do that. We cite that a lot, that they had an exercise, but nobody wrote it up. They didn't evaluate it. This is new. This is not the compliance team. This is the National Rural Rating System. And I tell you because it is so new. It's supported by both National Rural Health Association and by the National Association of Rural Health Clinics. You can use that QR code right there. What this does, it gives you a chance at 5-star ratings. Now they're only going to publish 5s and 4s, but you submit into this. It costs all of, I think, $250 or something. You submit your patient satisfaction surveys into this website, and then they rank and you can get a rating. Those bragging rights are worth a lot, especially where you have competition moving in your neighborhood, and you want, hey, who doesn't want to go to a 5-star clinic? And if you come out a 2-star clinic, it's also going to tell you got some work to do. Why is that? What's causing that? So it's something to do. You can go to National Rural Rating System website and learn more about that. And with that, I am through. I have lots of time for questions, which is good. There's my email. That's the best way to get me. I'm on the phone a lot, so the phone number doesn't really work very much, but certainly leave a message and I'll get back to you. Do we have any questions?
Thank you so much, Kate. If you guys have any questions, you can drop them in the chat here. And while people are getting their questions together, I do have one question for you, Kate. What role does technology or electronic documentation play in staying compliant today?
Oh, that's a broad question, Janai. So are you asking me about AI?
If it includes it, yes.
If it
Or
includes,
just technology in general.
well, of course, we should do more and more things leaning on technology. The only thing with AI, and it's a wonderful note taker, is you get the patient's permission, and you come into the room and you say, just so you know, this is being recorded for AI for my notes. It actually gives the provider more time to actually speak to the patient instead of worrying about typing, and that's quite acceptable. But you would need their permission. Verbal is fine because it's going to be in the recording when they say it. Um,
Nice. Nice. Oh, all right. Thank you so much. We have another question in the chat. For the program evaluation, are staff signatures required, or is it medical director, APP, or outside person sufficient?
For the program evaluation review, the staff signatures are required. There needs to be a training log that you reviewed that document with the staff. Good question.
Nice. Thank you. Keep the questions coming. You guys can put them in the chat. I have another question. So how do you recommend balancing compliance needs with limited resources?
Yeah, that's always a challenge. The best thing to do is divide, most of you have the checklist, maybe all of you, divide it into sections. So what's due monthly? What's due quarterly? What's due annually or biannually? And so you kind of keep a track of it that way. Use your calendars a lot. Try to make sure we're checking on things and delegate your managers. Delegate some of this. This is a team sport. One person cannot keep track of all this in a clinic.
Nice. Thank you. Yes, we'll get Kate's slides to you guys. Send it out in email. Any other questions? You can come off mute if there's anything else. Thank you so much, Kate, for sharing your knowledge and experience with us today. You gave us helpful tips and clear examples to better understand rural health clinic compliance. This conversation showed us that compliance is not just about following the rules, it's about making sure patients get the best care possible and keeping our rural health system strong. At NICER, we'll keep working to support clinics and share resources and advocate for the needs of rural communities. We hope to see you guys all again soon. I'm dropping the evaluation form in the chat there. If you guys would like to give us evaluation or anything, if you want CHES credits, please fill that evaluation and we'll get that for you. If there's no other questions, thank you so much, Kate. Thank you everybody for joining us today. And we'll get this recording on our website later on.
All right. Thank you so very much. Wonderful.
Thank you, everyone. Have a great afternoon.